Hello, I'm Nathan Byrne, and for my action project, I did From Exhaustion to Intervention, implementing a stage-based model approach to preventing physician burnout. I began by asking the question, what neurochemical changes are associated with chronic physician burnout, particularly in emergency medicine, and how do these changes influence a physician's physical health outcomes? To explore my question, I reviewed current research on burnout, physiological stress responses, and organizational factors that play into burnout. My goal was to find biological data and physiological stress responses that were indicative of chronic physician burnout. It is through this process of research that I learned that burnout is not acute. It progresses in stages rather than not progressing at all. Um, Burnout is best defined as a state of physical, emotional, and mental exhaustion accompanied by poor performance, depersonalization, and a diminished interest in one's work. Burnout then physiologically can lead to the dysregulation of the hypothalamo pituitary axis and the autonomic nervous system. These two major systems come together to regulate our stress and our homeostasis. This dysregulation alters cortisol patterns, cytokine levels, heart rate variability, and blood pressure regulation. These maladaptive endocrine responses can contribute to adverse health outcomes such as cardiovascular disease. It is important to note, though, that to this date, there is no conclusive evidence that there are biomarkers associated to burnout, which I believe that my action project could benefit this lack of research by having ongoing research throughout our action project, determining these biomarkers leading to even more beneficial intervention in the near future. But beyond the biology, of course, physiological stress plays a role, but burnout is largely an organizational issue. Organizational factors that contribute to burnout include excessive workloads, long hours, administrative burden, and lack of support that physicians typically undergo. During the COVID-19 pandemic, however, this was exacerbated and intensified as physicians experience unstable housing, even longer shifts, and overwhelming patient load, in addition to the aforementioned factors. During this time, even self-care couldn't help physicians, as one would typically think, take a bath, stretch, relax, do some yoga even. But no, many physicians turn towards substance abuse, putting a further strain on their long-term health, along with the risk of cardiovascular disease or hypertension, what have you. Based off of all this research, my key conclusions were burnout progresses in identifiable stages. It produces measurable physiological changes, and organizational systems, not individuals, are primarily responsible for the prevention of burnout. Therefore, any intervention must integrate both biological monitoring and organizational reform. So, my action plan uses a dualistic approach: clinical monitoring, where physicians will undergo quarterly wellness checkups on their physiological factors that are listed in front of us right there, and then psychological assessment using current on-staff mental wellness staff, such as social work and the already amazing program that St. Luke's has of counseling, will conduct these Maslach burnout inventory surveys that is used to determine indicators of burnout, which are emotional burnout, depersonalization, and reduced personal accomplishment. The stages I will use to approach intervention will be: one, early psychological signs, which could be cognitive fog or irritability; stage two, functional impairment, which could be, which some things that could be indicative could be absenteeism or poor performance; stage three, health deterioration, abnormal HRV or cortisol, or any of those aforementioned physiological signs; and then stage four, systemic breakdown, substance abuse, or even substance use in chronic illness. It's important to note that through stages one and two, we're trying to prevent escalation and restore function through task redistribution and reduced hours. And it's important to note that unless there are a physician is a locum tenens, then they are salaried. So a tailored approach will be implemented to fit the locum tenens hours that they need to reach. But if they are salaried, it will not affect their pay. So for example, we could offer a short period of paid leave if they are hourly. For more critical, that step 3 and 4, clinical care and crisis intervention will be brought up. Oh, sorry. Steps of the project: I will finalize a model and protocol, secure institutional approval through St. Luke's and the contractor physicians used there, Emergency Medicine of Idaho. I will recruit the physicians from Emergency Medicine of Idaho, and then I will conduct the baseline tests, so the psychological and the physiological. And then I will classify these physicians into the stages that I just talked about, and we will intervene as best as we see fit. I will then schedule the future quarterly wellness checkups, monitor and evaluate them, and then scale up the program from there. Collaborators and resources: St. Luke's Nampa Medical Center Emergency Department will be where I pilot my program, and then the adjacent urgent cares will be where I conduct the physiological testing. And then I believe that counseling has their own offices in the hospital itself, so I will be able to conduct my psychological wellness visits there. It's important to note that physicians are definitely overworked, but this isn't making them spend time in the hospital, like more time in the hospital. It's the same as an outpatient follow-up appointment that they would have with their primary care provider, or if they had a wound care appointment or a cardiologist. In the overview of their time, if they were to work 40 to 50 hours a week, these both wellness checks will be 1 hour each. So it would be approximately 0.36% of their time yearly. Chief Quality Officer Mark Urban, MD, will help me oversee with an administrative lens. St. Luke's Counseling Services, as I just mentioned, and then the tools: Maslach burnout inventory, HRV, blood pressure, cortisol, cytokine testing. Challenges and success: there has to be a culture shift. We must thwart the stigma. This is mental preservation, not weakness. Burnout is not weak. They're securing their jobs. They are securing their lives. They're taking care of themselves. Early approval preparation, is how I will fight against administrative wait times and possible resistance. Through all this persistence, I aim to achieve normalized physiological signs and normalized psychological signs through these physiological indicators of burnout and the Maslach burnout inventory. I will then know I will succeed when I see improved employee retention through physicians and physician engagement. I will also see the quality of patient care increase over time, hopefully. And then finally, my expansion will not just go across departments, but institutionally. And that is it. Thank you so much for listening.